So without further ado, I'd like to introduce the next speaker, Dr. Roy Brower. Roy is professor of medicine at Johns Hopkins University in Baltimore, Maryland, was the principal investigator on the NIH ARDSNet trial that was published a few months ago in the New England Journal, and he'll talk to us about our recruitment maneuvers necessary.
Well, thank you very much, Art, and thanks also to Siemens and the organizers of this meeting for the opportunity to come. As Art explained, I'm going to make some comments in relation to the simple question, in relation to the question with low tidal volume ventilation in ALI and ARDS, is recruitment necessary? So before addressing that question directly, I think it's useful to go back a little bit and think about how we got to the point of using small tidal volumes for ventilating patients with ALI and ARDS. As you know, your patients with ARDS have severe abnormalities in gas exchange, such as elevated dead space. A normal patient with a normal tidal volume has approximately 30% of that tidal volume dead space. In ALI and ARDS, not uncommonly as high as 60%. And the way that we traditionally have dealt with that problem is to increase the respiratory rate or the tidal volume. By so doing, we could maintain normal CO2 and pH in many cases. Also, our patients have severe abnormalities of oxygenation due primarily to shunt and low VQ regions in the lung. To compensate for that, we use PEEP and increase the fraction of inspired oxygen, but also we sometimes think to increase the tidal volume. So why have we traditionally increased the tidal volume? Well, these are data taken from dogs ventilated with a volume cycled mode. These are old data, 1964. As you can see on the vertical axis is plotted the change in the AA gradient per hour of observation while these dogs were simply ventilated with various tidal volumes. Those various tidal volumes per ml per kilogram shown on the horizontal axis. I know these numbers are small, so to help you put this in perspective, this is 10 milliliters per kilogram, this is 60 milliliters per kilogram. And what's obvious is that if you ventilate a dog with a generous tidal volume, that the AA gradient actually goes down, but if you ventilate with a modest tidal volume, then the AA gradient rises. And these workers reasoned that with a monotonous volume cycled mode of ventilation that there was some atelectasis accounting for the gradual rise in AA gradient. Next slide, please. Additional observations in humans by the same group of workers confirmed these findings. Humans undergoing anesthesia with controlled ventilation. On the left, a patient is ventilated with a generous tidal volume, resulting in a PCO2 in the low 20s. And as you can see, the PO2 here is maintained at a nice level over 150 minutes. But if humans are ventilated with a controlled mode of ventilation with a modest tidal volume, as shown here on the right, then the arterial PO2 gradually falls over these 2 hours of observation. In this case, the PCO2 is in the high 40 range. So these observations strongly suggested that ventilating with a generous tidal volume could be helpful to maintain arterial oxygenation. And especially in the challenging patients of ALI and ARDS, maybe it made sense, at least historically, why we chose a generous tidal volume, both to maintain oxygenation and CO2. However, as many of you know, it takes a lot of pressure to get a generous tidal volume into our ALI, ARDS patients. And that pressure was a tip-off that perhaps there was some injury occurring in the lung. Many workers and clinicians recommended using smaller tidal volumes, sacrificing the traditional objectives of acid-base balance and breathing comfort and oxygenation in order to achieve the objective of lung protection. So until recently, we struggled with the balance. Was it favorable to use a generous tidal volume and preserve gas exchange at the risk of causing ventilation-associated lung injury? or was it better to use a small tidal volume in order to achieve lung protection, but acknowledging that we would lose some benefits with respect to oxygenation, hypercapnia, and acidosis. The trial that we completed last year and published several months ago, we believe gave us a good answer to the question, is it better to use a smaller tidal volume than a traditional tidal volume? Is it more favorable to sacrifice the traditional goals in order to achieve the lung protection goals? As you know, the mortality rate of the patients that received a small tidal volume, 6 milliliters per kilogram predicted body weight, was lower, significantly so, than those that received a traditional tidal volume. This slide shows those tidal volumes as we use them. The traditional tidal volume group received, on average, during the first 4 days of this study, a tidal volume of about 11.8 milliliters per kilogram predicted body weight. That's equivalent to about 10 milliliters per kilogram measured body weight, which I think is how most clinicians have prescribed tidal volumes. Those patients randomized to the lower tidal volume received, on average, a tidal volume of 6.2 milliliters per kilogram. And the mortality rates, as shown here, very simply, 40% in the patients treated traditionally, 31% in those that received the lung protective approach with small tidal volumes. But some very interesting physiologic data came out of this as well that's relevant to the discussion that we have today. Namely, first, the ratio of arterial PO2 divided by FiO2 was lower in the patients that received the small tidal volume approach during the first 2 or 3 days after randomization, significantly so here. And the difference here, about 20 millimeters of mercury. This P to F ratio, as you know, it reflects in large part how difficult it is to oxygenate the patient. So it was more difficult to oxygenate these patients that received the small tidal volume. Now, I'll explain a little bit more about methodologies so as to better understand where we're going with that observation. In addition to controlling tidal volume, we also controlled PEEP and FiO2 in this trial. We aimed for arterial oxygenation ranges as shown here, and it was required that patients be on one of these PEEP FiO2 combinations. So a typical patient had PEEP 10, FiO2 50 or 60%. Because we were aiming for the same target ranges of arterial oxygenation, this graph shows that indeed that's what we had during the first several days after randomization. The two groups had essentially the same PO2 or O2 saturation. In order to maintain that same level of PO2, it was necessary to use a higher PEEP. So during the first 2 or 3 days after randomization, the PEEP levels in the 6 ml group were higher by about 1 centimeter of water, significantly so on days 1 and 2. A similar slide that shows FiO2 versus time looks just like this. So we needed to use slightly higher PEEP, slightly higher FiO2 to maintain the same level of arterial PO2. Also, we observed that the compliance of the respiratory system was lower in patients that received the lower tidal volume approach. Here are baseline respiratory system compliances prior to randomization, values taken during the first 4 hours, or excuse me, the last 4 hours prior to the initial ventilator changes. And then on days 1 and 3, values of respiratory system compliance were lower in patients that received the low tidal volume approach. So it appears, in summary, that with lower mortality, there was an interesting physiologic change which suggested that maybe not everything was better with the small tidal volume approach. There were increased requirements for PEEP and FiO2 and lower respiratory system compliance. And the most logical explanation for this is that the price to pay of using a lower tidal volume was that we lost some of the advantage in terms of maintaining oxygenation by reversing or preventing atelectasis. So we believe these observations represent greater atelectasis in patients that received the small tidal volume approach. These pressure volume curves are sketches that I drew just for conceptualization. These do not represent actual data because we did not obtain the data to create PV curves in these patients. But I think it's easy to imagine that in the patients that received the lower tidal volume, shown in pink, that the curve was shifted down and to the right. We used the smaller tidal volume, obviously, as shown here, than in the traditionally treated patients. Perhaps the better outcome was due to lower stretch at the high end of these curves. I think it's fair to put in this context that it's also possible that at least part of the improved outcome instead was due to less opening and closing with each breath. Perhaps there was less injury from opening, reclosing with this smaller tidal volume approach. Regardless of what the explanation is, the increased difficulty in oxygenating and the lower respiratory system compliance strongly suggests that there's greater atelectasis, and perhaps there is still some atellect trauma going on here, and for that matter, maybe we should be doing something to increase lung recruitment and further improve the mortality rate of patients with the disease. So what can we do to recruit the lung? This is simple stuff. The measures that I think are not controversial are first, prevent unnecessary de-recruitment, as occurs with unnecessary disconnections from the ventilator circuit, unnecessary suctioning, unnecessary agitation and coughing. But the two things that we can do that we have to think carefully about before we can adopt these measures as useful in relation to achieving the important outcome variables of mortality and related variables are, should we use higher PEEP than we use traditionally, and should we use recruitment maneuvers? Well, there's a long history of science that strongly supports the notion that higher PEEP, or some level of PEEP, is lung protective. And in relation to this, one of my mentors, Salbert Permit, whenever I tell him what we're thinking about and arguing about, he always tells me that's deja vu. We worked on this about 25 or 30 years ago. He and his colleague Faraday showed that in isolated perfused canine lobes, that when the lobes were ventilated with some level of PEEP, that there was preserved surfactant function, better than in lobes that were ventilated without PEEP. And then there's many studies in many species that showed reduced lung injury when some level of PEEP was added, or when a higher level of PEEP was used than a modest level of PEEP. And then most recently, very interesting data coming from animal experiments and from Marco Ranieri's human experiments, demonstrating clearly that with higher than traditional levels of PEEP, that there are reduced levels of inflammatory cytokines in the alveolar air space and also in the bloodstream. So there's ample rationale for using some level of PEEP and perhaps for using a higher level of PEEP than is used traditionally. If we use a higher PEEP strategy, then we can use a lower fraction of inspired oxygen to maintain an acceptable level of arterial oxygenation. So the higher PEEP, lower FiO2 strategy is beneficial in that we can cause perhaps less injury from opening and closing injury or shear forces-induced lung injury, and also perhaps less oxygen toxicity. But if we stay with a lower PEEP, higher FiO2 strategy, then there's less injury from lung stretch. Of course, with higher PEEP, we tend to get to higher lung volumes and levels of distension and stretch. It's easier to maintain arterial PCO2 with a lower PEEP strategy if we were going to put a plateau pressure limit. If we use a plateau pressure limit along with a higher PEEP, then of course the tidal volume becomes squeezed perhaps to some very low levels. And of course, higher PEEP will cause circulatory depression. Higher PEEP also can increase the resistance of the bronchial circulation and under some circumstance increase dead space. So there are risks and benefits of both approaches, and at this point we're not sure which one is better. Well, so if you use a small tidal volume, what data do we have to tell us that higher PEEP is better than a traditional level of PEEP? Well, one level of evidence, or one source of evidence, I think, is Marcelo Amato's trial, where there was such a striking difference in mortality in the patients that received the higher PEEP. It's fair to add that those patients also had a smaller tidal volume and other measures to protect the lung. So we're not exactly sure which of those measures was playing the most important role. I think these data, taken from 2 trials of high-frequency oscillatory ventilation in neonates, are very interesting in the context of, with a small tidal volume, is recruitment necessary? The 2 very similar trials of high-frequency ventilation, the techniques were very similar, with one exception, namely that in the trial on the left, hypoxemia was treated by increasing FiO2 and then mean airway pressure, and there were no beneficial effects here. In contrast, in this other trial, when mean airway pressure was purposely increased to higher levels, then there appears to have been some beneficial effects. And there were a couple of other similar trials that used an elevated mean airway pressure with high-frequency ventilation, and they also suggested a beneficial effect. We're currently conducting a trial in adults with ARDS in order to answer the question, will we get a better outcome if we use a higher than traditional level of PEEP? So the two arms of this new protocol, which opened last November, one arm is a lower PEEP, higher FiO2 strategy, which I call traditional, and the other arm is higher PEEP, lower FiO2. This briefly explains how we're doing the study. This PEEP FiO2 scale is exactly what I showed you on a previous slide. A typical patient is on a PEEP of 10 and 50 or 60% oxygen. We call that a traditional approach. With our higher PEEP, lower FiO2 strategy, the same patient might be on a PEEP of 14 or even 16 with an FiO2 of 30 or 40%. So we've randomized approximately 250 patients into this trial so far. But we need to know the answer to the question. We need to know the results of this study before we really know if the higher PEEP strategy is better. Brief comments on recruitment maneuvers. Many of you will recognize this as data from Dr. Lachman's laboratory in a lavage model of acute lung injury. Recruitment maneuvers with peak pressures of 40, 50, and 60 centimeters of water cause these striking increases in arterial PO2 from as low as 50 to as high as 560 millimeters of mercury, but frequently the pressures necessary to cause these striking improvements are at levels that none of us are comfortable, or few of us are comfortable with. So we don't know if recruitment maneuvers are going to be effective at safe or acceptable levels, and for that matter, whether we will get a better outcome. So how much recruitment pressure is necessary in our patients with ARDS? How long do we have to sustain the pressure? How often? Should we raise the PEEP if there's a response, or should we maintain the PEEP? What about the risk-to-benefit ratio? We're not sure about that. And last slide, please. As always, we have to balance risks and benefits of any new idea. I think there's compelling evidence from laboratories to suggest we may get a better outcome if we recruit the lung, but we're going to pay a price if we recruit the lung, price such as Art Slusky was mentioning earlier. And I briefly mentioned. Without knowing the results of good randomized controlled trials, we'll still be doing the best guess that we can take. Thank you very much.